Welcome to Virtual APSA 2021 Scientific Session 1. I am Dr. Megan Arnold from the University of Michigan C.S. Mott Children's Hospital, and I will be one of your moderators for this session.
And I'm Dr. Stephen Allman from Driscoll Children's Hospital in Corpus Christi, Texas.
And I am Dr. Jeff Gander from the University of Virginia Children's Hospital. We are all members of your 2021 APSA Program Committee. We are delighted for you joined us for the scientific session number 1, focusing on neonatal surgery. In this session, we have 4 poster presentations that will run in succession without any video discussion. If you have questions for an author during their presentation, please share them by using the chat function. After the poster presentations, the moderators will summarize what we felt were the highlights of each poster. Then, we will begin introducing each of the 8 oral presentations. So, without further delay, we will begin with the 4 2-minute poster presentations.
Our first poster presentation will be made by Dr. Hiroyuki Koga from Juntendo University in Tokyo, Japan. His presentation is entitled Laparoscopic Kasai Portoenterostomy, Trends in Morbidity and Redo Surgery from 10 Years Experience.
We investigated postoperative morbidity and the indications for reduced Kasai portoenterostomy based on 10 years experience of performing laparoscopic Kasai for biliary atresia. 39 patients who had laparoscopic Kasai at 2 hospitals with the same management protocol were reviewed retrospectively. Jaundice disappearance was achieved in 31 of our 39 patients, giving a jaundice disappearance ratio of 79.4%. 7 reduced Kasai were indicated for persistent jaundice without jaundice disappearance in 5 patients, and relapse of jaundice after jaundice disappearance in 2 patients. Reduce were performed open in 3 patients and laparoscopically in 4 patients. Jaundice disappearance was achieved in 5 patients after reduced Kasai. 4 are laparoscopic and 1 was open, giving a jaundice disappearance ratio of 71.4%. The remaining 2 patients remained jaundiced. From 10 years experience, laparoscopic Kasai would appear to be a valid treatment option. Reduced Kasai would appear to be best performed laparoscopically, and follow-up of laparoscopic Kasai cases must include monitoring for bile leg formation. Thank you for your attention.
Our second poster presentation will be made by Dr. Koga Thompson from Boston Children's Hospital. His presentation is entitled Predictors of Anti-Reflux Procedure Failure in Esophageal Atresia Patients.
Esophageal atresia patients often undergo anti-reflux procedures due to refractory GERD. In this population, these can be challenging, with high reported failure rates. This study consists of a single-center retrospective review of all patients with esophageal atresia who underwent an anti-reflux procedure from 2002 to 2019. Using a time-to-event analysis, we evaluated predictors of RAP failure, defined as hiatal hernia recurrence, RAP migration or loosening, or need for reoperation. There were 121 patients who underwent 140 operations at a median age of 13.5 months. Nearly 90% underwent a full 360-degree Nissen-type fundoplication, with 75% undergoing an open operation. With a median follow-up of 3 years, about a third of these procedures failed, but only 14% needed reoperation. Median time to failure was about 9 months. Mesh reinforcement to support the RAP or crural closure, and endoscopic guidance to locate and mark the GE junction to ensure the true GE junction was intra-abdominal and the RAP was performed at or slightly above this level, were both found to provide protection against anti-reflux procedure failure. On multivariate time-to-event analysis, a partial fundoplication and minimally invasive approach were both strong predictors of failure. The partial RAP was never our preferred approach, but was performed in those with microgastria or severely damaged stomachs, while the minimally invasive approach may be more likely to fail due to the decrease in postoperative adhesions. In conclusion, anti-reflux procedures in patients with esophageal atresia are challenging. About a third fail, often within the first year post-op, though only 14% require reoperation. In this patient population and in our hands, it appears that performing a complete wrap via laparotomy provides the least risk of failure. The use of mesh and endoscopic guidance warrant further study. Thank you.
Our third poster presentation will be made by Dr. Jay Meisner from Boston Children's Hospital. His presentation is entitled Frequency and Natural History of Recurrent Laryngeal Nerve Injury in Complex Pediatric Esophageal and Airway Surgical Interventions.
Pediatric vocal cord dysfunction, where one or both vocal cords do not move normally, occurs between 4 and 30% of the time after surgery for esophageal atresia. Vocal cord injury affects a child's ability to swallow, breathe, and talk safely. We performed a study looking at vocal cord injury rates in patients who underwent at-risk procedures, where one or both of the recurrent laryngeal nerves were at risk, during a 32-month study period. All of our patients get pre- and post-operative vocal cord checks by awake, flexible nasolaryngoscopy regardless of symptoms. 299 patients underwent 419 at-risk procedures. 50% of these procedures occurred in a reoperative setting. There were 241 preoperative vocal cord checks. 21% had pre-existing vocal cord injury. 16% of these patients with pre-existing vocal cord injury recovered by the end of the study period. Postoperatively, there were 244 vocal cord checks. 21% of these sustained new vocal cord injury. Of these new vocal cord injuries, 60% were symptomatic and about 40% were asymptomatic. 41% of the new vocal cord injuries recovered function on subsequent vocal cord check exam at a median 3 months from surgery. Postoperative vocal cord injury after cervical or thoracic operations are common and are likely underreported. A substantial proportion of these patients are asymptomatic, but routine pre- and postoperative awake, flexible nasolaryngoscopic exams should be performed in all patients regardless of symptoms.
Our final poster presentation will be made by Dr. Walker Short. His presentation is entitled Human umbilical vein endothelial cells from CDH patients demonstrate propensity for endothelial to mesenchymal transition.
Good afternoon. I'm Walker Short, a surgery resident in Houston, Texas. CDH occurs when there is failure of the diaphragm to completely form in utero, leading to organ herniation and lung compression. Surprisingly, a majority of the morbidity and mortality resultant from CDH is secondary pulmonary hypertension, which persists even after surgical correction of the diaphragmatic defect. Current pulmonary hypertension treatments are aimed to improve pulmonary vasodilation. However, the vasculature has an incomplete response, likely due to the significantly increased perivascular fibrotic extracellular matrix, or ECM, which acts as a physiologic lead pipe around the vessel. This lead pipe may result from endothelial to mesenchymal transition, or endo-MT, a process seen in other pediatric pulmonary hypertensive diseases. However, this process has yet to be demonstrated in the pathogenesis of pulmonary hypertension in CDH. Therefore, I hypothesize that endo-MT contributes to the pathologic vascular ECM remodeling seen in CDH-PH. To test this hypothesis, I harvested the endothelial cells, or HUVECs, from umbilical cord sections of newborn babies with CDH. These cells were treated with TGF-beta, an established mediator of endo-MT, for 48 hours. First note, a markedly intrinsically elevated rate of proliferation in HUVECs obtained from CDH patients. Though TGF-beta did not substantially affect proliferation, it did incite a greater upregulation of alpha SMA and collagen 1 in these endothelial cells, which are markers of endo-MT. miR30A, which is protective against the endo-MT process, is upregulated in healthy controls while downregulated in CDH HUVECs. Finally, DLL4, a known downstream target of miR30A that works through the Notch pathway to promote endo-MT, increases in CDH HUVECs exposed to TGF-beta. In conclusion, HUVECs from diseased patients are more susceptible to endo-MT in response to TGF-beta compared to healthy controls, and dysregulation of the miR30A pathway in patients with CDH may represent a potential therapeutic target to halt the progression of endo-MT in utero.
The 2021 APSA Program Committee thanks Drs. Koga, Thompson, Meisner, and Short for presenting their work. Dr. Koga presented an impressive series of laparoscopic portoenterostomies performed at 2 hospitals over a 10-year period. In these 39 patients, nearly 80% experienced resolution of their jaundice. 7 patients with persistent or recurrent jaundice underwent redo portoenterostomy, with 4 being done laparoscopically. In this series, laparoscopic redo portoenterostomy was associated with a resolution of jaundice in all 4 patients, compared to only 1 of 3 patients who underwent an open reoperation. At 2 years of follow-up, most patients in the cohort were alive with their native liver in place. Dr. Thompson presented data from a single-center retrospective analysis on the use of anti-reflux procedures in patients with esophageal atresia. In this cohort, 140 anti-reflux procedures were performed in 121 patients. Overall, 1/3 of patients experienced RAP failure, and failure occurred at a median of 9 months postoperatively. Of those who failed, only 14% required reoperation, however. RAP failure was associated with laparoscopic procedures and those with less than a 360-degree RAP. Decreased failure rates were seen if mesh was used to reinforce the crural repair and if endoscopy was used to confirm GE junction location in the abdomen at the time of the procedure.
Dr. Meisner presented data suggesting that patients undergoing complex primary or reoperative esophageal or airway procedures should have pre- and postoperative laryngoscopy to assess vocal cord function. This study was a 32-month single-center retrospective study of 419 procedures in 299 patients, with half of the procedures being reoperative. Preoperative laryngoscopy found 21% had pre-existing vocal cord injury, with 16% recovering function. Postoperative laryngoscopy found 21% sustained a new injury, with 40% being asymptomatic and 41% recovering function. These data suggest that about 1 in 5 patients undergoing a primary or redo complex upper aerodigestive tract operation will sustain a vocal cord injury, 20 to 40% of which will recover.
Dr. Short presented work where his group attempted to understand the role endothelial to mesenchymal cell transition plays in vascular remodeling with pulmonary hypertension and CDH. He harvested live endothelial cells from patient umbilical cords with CDH, also known as UVECs. They were treated with TGF-beta1 to transition them to mesenchymal cells. The research showed that CDH UVECs have a very high proliferation rate, and that treatment with TGF-beta1 increased the cell's expression of markers for transition to mesenchymal cells more than control. Additionally, signals that are protective of transition from endothelial cells to mesenchymal cells were downregulated in CDH UVECs, showing that the patients with CDH seem to have more propensity for this transition. The group concludes that this pathway may play a role in future therapeutics for pulmonary hypertension for CDH. We will now begin the oral presentations selected for scientific session number 1. Each presentation will be 4 minutes long and followed by a 4-minute interactive discussion between the author and a distinguished discussant. As questions come to mind, please enter them in the chat box and we will answer as many as time will allow. There are 8 abstracts in the session dedicated to neonatal surgery.
Our first oral presentation will be given by Dr. Janine Weller from Johns Hopkins University. Her presentation is entitled Laparoscopic versus Open Surgical Repair of Duodenal Atresia in Neonates, a NISQIP Pediatric Analysis. Dr. Weller.
Thank you for the opportunity to present this research, and I have nothing to disclose. Duodenal atresia occurs in 1 in 5 to 10,000 live births in the United States. Since the first described case in 2001, laparoscopic repairs have become an alternative approach to the open repair, and single-center studies suggest comparable outcomes between the 2 approaches. The aim of this study was to use a national database to examine these short-term postoperative outcomes for infants who underwent laparoscopic versus open duodenal atresia repairs. So we used data from the NISQIP pediatric database and created a cohort of infants aged less than 1 week old who underwent a duodenal atresia repair. We primarily restricted the inclusion criteria to this group in order to minimize heterogeneity between our comparison groups. We then used an intention to treat analysis setup where we examined differences in intraoperative and postoperative outcomes by the operative approach and used multivariate regression analyses that allowed us to account for the significant right skew in our data. For the 335 neonates who met inclusion criteria, there were 289 open and 46 laparoscopic cases, with 16 cases converted to open. The median age at operation was 2 days old, and there were no significant differences between groups based on preoperative covariates. And this included associated comorbidities of malrotation, cardiac defects, or Down syndrome. We were interested in looking at trends of operative approach over time within the data set and found no major changes in the proportion of cases performed laparoscopically or the proportion of cases converted to open after the year 2016. As you can see, there were significantly fewer cases reported in 2015, and we postulated this was a result of missing data, possibly from the switch from ICD-9 to ICD-10 postoperative diagnosis coding, and which happened in the year 2015. This table shows the frequencies of 30-day postoperative complications seen in our cohort. Overall, we found no significant differences by operative approach. The most commonly seen complications were bleeding requiring transfusion and reintubation. There were 3 deaths seen in this cohort, and all occurred after open repairs. And finally, of the 13 infants who required reoperation, 3 underwent enterostomy repairs, and 2 others required small bowel resections, one of whom had a documented acute intestinal infarction. After we adjusted for confounders, our results showed that laparoscopic cases had on average a 57-minute increase in operative time, and that's an increase of almost 50% when compared to the open cases. Conversely, postoperative lengths of stay were on average 4 days shorter after laparoscopic repairs. And looking at the composite variable of 30-day postoperative complications, there were no significant differences between the laparoscopic and open groups, which confirmed what we had seen on the univariate analysis. So in conclusion, we found laparoscopy was uncommon for duodenal atresia, but laparoscopic repairs had comparable safety to open repairs. Laparoscopy had longer operative times, but shorter lengths of stay. And while our results were limited by a small sample size and lack of long-term outcomes, the data supports continued use of laparoscopy for duodenal atresia repairs. I'd like to thank the Pediatric Surgery Department at Hopkins for the opportunity to work on and present this research. Thanks.
Thank you, Dr. Weller. The invited discussant for this paper is Dr. Ann Fisher. Dr. Fisher is the Medical Director of Pediatric Surgery for Tenet, Florida Physician Services.
Dr. Weller, thank you for an excellent and timely study from Johns Hopkins on an area of advanced laparoscopy that was introduced over 2 decades ago by Dr. Bax and Dr. Rothenberg, but not widely implemented. My first question is, over 30% of patients that underwent laparoscopic repair, they were converted to open. Do the authors assume that this is the expected norm? Have we reached steady state? Or is this reflect that our society is in a learning curve of implementation?
Yeah, I think that's a really great question. You know, the 33% conversion rate that we see in our data does match with what's previously reported, which is really on a range from anywhere from 0 to 35% in small studies published over the past 10 years. You know, I think given the rarity and also the variability that we're seeing in these cases, it's entirely plausible that there is a learning curve here. We tried to look at this by looking at the trends over time and didn't find any significant changes in what was effectively 3 years worth of data. Ideally, what we'd want is a longitudinal data set where we'd be able to track multiple cases by physician, by surgeon, and by center. And then if we had a large enough sample size, 400, 500 cases, we could do a mixed effects model and really understand that if there's a learning curve going on here. Unfortunately, right now, we don't have either the sample size or kind of the data set that supports answering that question. In summary, I think probably yes.
Originally, when a laparoscopic repair was introduced, there was radio silence after the initial reports, given a leak rate. Do the authors think that the numbers in the study are even powered to detect approximately 3% leak rate when only 9% actually ended up receiving the laparoscopic approach?
Yeah, you know, we did find this big class imbalance, I guess you could call it, where, one laparoscopic case to around 6 open cases. And yeah, I think when you crunch the numbers, it's something like you're powered at about 30% to detect a 10-fold difference between, if you were assuming a 0.3% leak rate in the open and a 3% in the laparoscopic. I think we don't really have the sample size, as you suggest, to find that, nor do we have the variables to really detect it. That being said, there is it might be better served answered in a meta-analysis, for example, of previous, and I think there has actually been published one in 2017 that found no difference.
Thank you. The difference in length of stay is assumed to be related to an ileus. However, commonly, open repairs use transanastomotic feeding tubes. Laparoscopic repairs tend to use an NG tube. This difference in management of the tubes may be confounders, explaining the large difference in length of stay. Please comment, since these details are not really detected in a NSQIP type of study versus a case-controlled study. And yet, like lat pyloromyotomy story, the difference was really related to the underlying associated regimen of feeding, not the surgery.
Yeah, so another limitation of our data set is we can't really answer the causal questions. I think at Hopkins, we see it's very rare to have these transanastomotic tubes placed, but that being said, we know there's practice variation in across the centers, and that could explain these findings for sure. Ideally, we'd want to be able to have a data set that looks at, both intraoperative and then postoperative, really follows the course of these kids to be able to distinguish the difference. What we can say is that it's associated, and we don't find while we find a difference in length of stay and we don't know why, we could use that to help inform setting up a duodenal atresia specific database that would better answer that question.
Thank you.
Thanks.
Thank you, Drs. Weller and Fisher, for the presentation and discussion on duodenal atresia repair.
Our second oral presentation will be given by Dr. Rebecca Savari from the University of Miami Miller School of Medicine. Her presentation is entitled, Outcomes for LADS Procedure, Does Approach Matter? Dr. Savari.
Hello, my name is Rebecca Savari, and I'm going to be discussing outcomes for LADS procedure and whether or not surgical approach matters. I have nothing to disclose. A little background information. Open LADS procedure is the gold standard for treatment of intestinal malrotation. Laparoscopic LADS procedure has proven to be a safe and feasible alternative with improved short-term outcomes. However, it is still underutilized, and information about long-term outcomes and readmissions are largely unknown. So the purpose of our study was to compare nationwide outcomes of laparoscopic versus open LADS procedure for the treatment of intestinal malrotation. We used the nationwide readmission database from 2010 to 2014 to look at patients who were less than 18 years old with a diagnosis of intestinal malrotation who underwent surgical intervention with elective LADS procedure. Patients were excluded if they were newborns or if they underwent emergent LADS procedure. Our primary outcome was readmission for any reason within the year of index hospitalization. Overall, we had 1,343 patients included in the study. 56% were female and 78% were less than 13 years old. 61% of operations occurred at large hospitals and 94% at teaching hospitals. The most common congenital anomalies were cardiac and chromosomal. During index hospitalization, the majority of patients underwent an open LADS procedure, with only 22% receiving a laparoscopic approach. There was an 85% rate of appendectomy. The most common associated diagnoses and complications on index hospitalization were GERD, small bowel obstruction, nausea, vomiting, diarrhea, and postoperative GI dysfunction. All other diagnoses and complications were less than or equal to 5%. Overall, we had 206 patients readmitted, 8% within 30 days, and 15% within the year of index hospitalization. The majority of these readmissions were unplanned. The most common diagnoses for readmission were GI issues and infection. 31% of patients were readmitted for small bowel obstruction, of which 68% required operative intervention. Our overall rate of redo LADS was less than 4%. So when comparing approaches, laparoscopic LADS procedure was utilized less frequently. However, it resulted in shorter length of stay, was less costly to hospitals, had fewer associated infections and GI issues during index hospitalization, had lower readmission rates, and ultimately had the same rate of readmission for small bowel obstruction and volvulus. So to conclude, outcomes and readmission are similar between laparoscopic and open LADS procedure, and our rate of redo LADS was lower than previously reported. However, laparoscopic LADS procedure continues to be underutilized despite these comparable outcomes. I would like to acknowledge these residents and faculty members for their contributions to the study. These are our references. And this is my contact information. I'd be happy to answer any questions that you may have. Thank you so much for listening.
Thank you, Dr. Savari. The invited discussant for this paper is Dr. Wolfgang Stair. Dr. Stair is the medical director of the surgery program at Presbyterian Hospital in Albuquerque, New Mexico. Dr. Stair.
Thank you, Rebecca, for using such an interesting approach for speaking about such a rare disease and rare surgery. Did I hear you right that 4% of the patients who underwent a LADS procedure needed a redo LADS procedure?
Yes, so our total cohort consisted of 1,343 patients. 206 patients were readmitted, and of those readmitted, less than 4% underwent the redo LADS operation, all of which actually occurred within 5 days of the index operation. So this means that our overall rate of redo LADS for the total cohort was actually less than 1%.
Thank you for that. And do you know, because these are prophylactic LADS procedures, do you know anything about the why and how these were diagnosed?
So unfortunately, due to the granularity of data that's provided by the NRD, we're not able to determine if patients were symptomatic or how they were diagnosed. This is definitely one of the limitations of the database. However, in order to have the most homogeneous sample population possible, we did exclude those with volvulus because we wanted to investigate elective, presumably prophylactic LADS procedures. In addition, since most LADS performed for volvulus are done open, and we wanted to investigate outcomes of laparoscopic versus open LADS, we looked specifically at elective isolated LADS procedures.
Thank you for that. So it just happened so that this morning I operated on a 13-year-old patient with trisomy 21, and we did a prophylactic LADS procedure. And I was speaking with the anesthesiologist, and one of the questions came up was, do you know in your data set how many of these patients did have trisomy 21 or other chromosomal abnormalities?
So the most common comorbidities in our overall patient population was cardiac at 12% and then chromosomal at 8%. There was no distinction between trisomy 21 or 13 or 18, but 8% total chromosomal abnormalities.
Thank you for that. So my last question, if you had a child today and you were diagnosed with, or your child was diagnosed with a asymptomatic intestinal malrotation or anomaly of intestinal rotation, which is how we're supposed to call this now, what procedure would you like for your child to have?
So that's a great question. Our study, along with numerous others, have shown the benefits of laparoscopy in LADS procedures. One of the biggest fears with the laparoscopic approach is the risk for recurrent volvulus or the need for redo LADS. However, this really has not panned out in literature or in our study, as we found equal, if not improved outcomes with our laparoscopic approach. So although the nationwide utilization is less in younger children, laparoscopic LADS can be done practically at any age, even in the newborn period. At our own institution, amongst many others, I'm sure, laparoscopic LADS is already the standard of care. However, like any laparoscopic procedure, there's definitely a learning curve to be taken into consideration. So for surgeons who are comfortable and confident in laparoscopy, laparoscopic LADS should be the preferred approach, and this is what I would advocate for if my own child had intestinal malrotation.
Thank you so much. I don't have any other questions. Thank you for your data and your abstract.
Thank you so much.
Thank you, Dr. Savari and Dr. Stair, for your presentation and discussion of the surgical approach to the LADS procedure. Thank you.
Our third oral presentation will be given by Dr. Nili Hafez from Indiana School of Medicine. Her presentation is entitled Surgical Needs and Survival in Trisomy 13 and 18, a 30-year review. Dr. Hafez.
Hello, and thank you for this opportunity. My name is Nellie Hafez, presenting Surgical Needs and Survival in Trisomy 13 and 18, a 30-year review. Trisomy 13 and 18 are the most common chromosomal aneuploidies after trisomy 21 and are often associated with neurodevelopmental, cardiac, musculoskeletal, and intestinal comorbidities. Previously thought to be incompatible with life, there's growing acceptance of longer-term survival in these children who may live to lead meaningful and happy lives. Given these beliefs of early mortality, surgical disease burden and outcomes are unclear, making patient selection and family counseling difficult. Our goal was to explore the surgical history of trisomy 13 and 18 patients and to better understand factors associated with mortality after surgery. And we hypothesized that there would be predictors associated with mortality after surgery. We did this through an extensive retrospective review spanning 30 years of all patients treated at Riley Hospital for Children with the diagnosis of trisomy 13 or 18. And our main endpoints included understanding overall mortality, mortality anytime following surgery, and factors associated with this mortality after surgery. 118 patients were selected for review. Demographically, the majority were female, and nearly 30% had incomplete trisomy, including mosaicism or translocation. 85% of patients had 4 or more comorbidities, including neurodevelopmental, cardiac, airway and pulmonary, and GI disease. Before getting into the surgical history, we first looked at mortality overall across all patients and observed that 75% survived to initial hospital discharge lasting a median of 13 days. 77% of deaths occurred by 6 months at a median age of 42 days, and by 10 years, survival was 33%. Higher birth weight and higher gestational age were less predictive of overall mortality, while complete trisomy, cardiac, musculoskeletal, and general surgical disease, especially TEF, were more predictive of overall mortality. Now looking at surgical history, more than half underwent an invasive procedure by median age 3 months, with the majority of these performed after initial hospitalization. There was a large breadth of procedures performed, but by far the most common were general surgical procedures, the breakdown of which are shown here. As seen, mortality after undergoing surgery was highest after TEF and CDH repairs. Now looking at mortality after surgery, we found that complete trisomy and undergoing general surgery, including TEF repair, were more predictive of postoperative mortality. We additionally noted that those who underwent any procedure had significantly lower mortality risk over time compared to non-surgical patients. Here, survival in surgical patients according to trisomy status is plotted out in a Kaplan-Meier curve over the 30-year study period, and it demonstrates a marked difference in survival in these two populations, highlighting the importance of knowing the patient's genetic status preoperatively. In conclusion, patients with trisomy 13 and 18 have many comorbidities and vast general surgical disease burden. Here we found that complete trisomy and undergoing general surgery was associated with higher mortality after surgery. However, those surviving to undergo surgery were more likely to survive overall. With growing acceptance of longer-term survival, the general surgical disease burden in this population will grow, and this study highlights the importance of having a close working relationship with the genetics team during the preoperative process and as a starting step towards better patient selection and family counseling. Thank you.
Thank you, Dr. Hafez. The invited discussant for this paper is Dr. Bob Cusick. He's a pediatric surgeon at Children's Hospital and Medical Center of Omaha. Dr. Cusick.
Dr. Hafez, that was a great presentation. Thank you for the opportunity to discuss this paper. This is a very important topic and is quite a large database of 118 patients treated over 30 years. Many of us pediatric surgeons have tackled these difficult patients over the years, and it's nice to have some guidance. So thank you for your contribution to the literature. My first question would be, it's difficult to determine whether we're doing the right thing. And from your data, can you really tell us if you were able to increase the survival in this difficult patient population, or simply is it patient selection by which ones get operations?
So thank you for allowing me to share this work, and thank you, Dr. Cusick, for this very important question in particular. While the data does show that there is a strong correlation with lower risk of death over time in the surgical trisomy 13 and 18 patient, it's an important finding that needs to be interpreted with a lot of caution. And I don't think that our data here fully supports the notion that aggressive surgical approach can improve outcomes directly. In our cohort, we saw that the majority of our patients died within the first 3 months of life. And at the same time, we saw that the median age of our first procedure was right around that 3-month period. And so I believe that many of our surgical patients were inherently self-selected as long-term survivals purely because they made it to that point. Nonetheless, I do think that our data does show that surgical interventions don't hasten mortality, and that surgeons need to approach the consultation for a trisomy 13 or 18 patient with much less pessimism than previously held.
Now I've got some 2 more questions for you. Now it gets more difficult. In my experience with these patients, I've had some parents that are very aggressive at wanting surgical intervention. I think of a child that was less than 2 kilos that had a CDH and required ECMO. And, my question for you is, who should be making the decisions about being aggressive surgically? I can tell you a lot of the caregivers were concerned about how aggressive this family was with their child. So should it be the physician, the surgeon? Should it be the family? Should it be an ethics committee? What are your recommendations?
So it's obvious that the care for the trisomy 13 and 18 patient in general is complex and needs that multidisciplinary approach, which includes obviously the neonatology team, the palliative care consulting physicians and surgeons, social work, and when needed, the ethics team. But when it comes down to the surgical decision making, and when it's been decided that a surgical intervention would be indicated, I think it still ultimately comes down to the surgeon to offer that operation to that patient and family. And I hope that this data here helps the surgeon in that process in assessing that surgical trisomy 13 and 18 patient as a surgical candidate, and to better shed light to families who may be offered or not these procedures about what the expectations short and long term are if they go through with a procedure.
Okay, one final question then. I'm going to ask for kind of a summary of the topic. You've really reviewed the largest series that I know of these patients at a single institution. And so what's your thoughts, you as a group of authors, as you write this paper? Should we as pediatric surgeons be more aggressive in the care of these patients? Some people have drawn the analogy to trisomy 21, and 30 years ago, we were much less aggressive with those patients. And I think that was probably wrong. But these are very different than trisomy 21 patients. So kind of what's your general guidance that you can give us as pediatric surgeons?
So that's a great question. I think we still do see a lot of patients who only survive that short lifespan. But what we also saw was that there was a sizable number of patients who survived past that initial 3 to 6 month period. And these patients often need surgeries for continued management and care. What we saw is that if they were able to survive that initial 3 to 6 month period, then it was likely safe to offer that patient a procedure such as, for example, a G-tube, a surgical G-tube.
We also saw alternatively a few subset of patients, for example, the CDH and the TEF kids, that we are a little bit more cautious about in that initial consultation period, because we know that they really do worse than other patients. And lastly, and maybe equally as importantly, the data demonstrated the importance of knowing the cytogenetic status of that patient, if at all possible. What we saw here in the long term was that most of our survivors were those with incomplete cytogenetic status, either mosaicism, translocations, or partial duplications. And if we can know that in that initial perioperative period, before, for example, before they are discharged home, we can make a more direct statement about their survival, and we can allow for better informed consent during that process for the families.
Right. That was an excellent presentation, excellent answer. So thank you for your time.
Thank you so much. And thank you again for the opportunity.
Thank you, Drs. Hafez and Cusick, for your presentation and discussion on the surgical needs of trisomy 13 and 18 patients.
Our fourth oral presentation will be given by Dr. Mark Fleming from the University of Virginia Health System. His presentation is entitled Clinical Regression of Inguinal Hernias in Premature Infants. Dr. Fleming.
Thank you for the opportunity to present our work. We have no disclosures. The incidence of inguinal hernias approaches 30% in premature infants, with reported incarceration rates as high as 39%. There are ongoing discussions regarding the optimal timing of repair. Most infants diagnosed with an inguinal hernia undergo repair in a neonatal period prior to hospital discharge. Avoiding the risk of inguinal hernia incarceration continues to be the main driver for consideration of early repair. However, some pediatric surgeons offer repair in a delayed fashion after discharge, especially with concerns for the technical difficult nature of the operation and anesthetic considerations. Unlike umbilical hernias, inguinal hernias are not felt to resolve spontaneously. However, a small study was published in 2000 that demonstrated spontaneous regression of inguinal hernias in a cohort of preterm female infants. The purpose of our study is to present a series of premature infants whose families elected to delay repair of their inguinal hernias and developed clinical regression of the hernia. Presence of an inguinal hernia was determined by physical examination by an attending pediatric surgeon in our neonatal intensive care unit in premature males and females. If no urgent indication for repair was present and families elected not to participate in the hernia in premature infants trial, they were offered early repair prior to discharge or a delayed repair after 55 weeks corrected gestational age. Families electing for delayed repair were prospectively followed. Patients were excluded from final analysis if they were older than 55 weeks corrected gestational age at the time of consultation, lost to follow-up, diagnosed with a terminal illness, or transferred to another institution for their care. For the delayed group, repair was offered after 55 weeks unless parents had not seen an inguinal bulge for over 1 month, and the hernia was unable to be elicited on physical examinations by the attending pediatric surgeon. In addition to demographic data such as birth weight, gestational age, and sidedness of the hernia, we also collected information on clinical regression of the hernia, time to clinical regression, and whether or not patients experienced an incarceration episode. A total of 87 premature infants with inguinal hernias were identified. 5 patients were excluded prior to further analysis. Of the 82 patients remaining, 68 elected for delayed repair. We saw clinical regression of hernias upon follow-up examination in almost 34% of patients who delayed repair. 45 infants ultimately underwent herniorrhaphy. When we looked for sex differences among the delayed repair group, we saw a significantly higher proportion of premature male infants diagnosed with inguinal hernias. No differences in birth weight, gestational age, or corrected gestational age were seen. Of the 23 patients that were noted to have clinical regression, a significantly higher proportion were female, 52.6%. Also important to note that the overall median time from birth to clinical regression of the hernias of the entire group was 27.3 weeks. When analyzed further with univariate logistic regression, a significant association between hernia clinical regression and female sex was noted. As for the 45 patients who ultimately underwent herniorrhaphy, 84.4% safely persisted to 55 weeks corrected gestational age. 4.4% experienced an incarceration with no loss of bowel. 8.8% appeared symptomatic, requiring repair prior to 55 weeks. 2.2% had a concurrent surgery. No infants in the study suffered any long-term morbidity. In conclusion, delaying inguinal hernia RFE in a series of premature infants until after 55 weeks corrected gestational age revealed that 1/3 of infants, especially females, had hernias that clinically regressed upon follow-up examination. Furthermore, our study showed that at least 84% of premature infants in this series safely delayed hernia RFE until after 55 weeks corrected gestational age. Thank you, and I'm happy to take any questions.
Thank you, Dr. Fleming. The invited discussant for this paper is Dr. Martin Blakely, a pediatric surgeon at Vanderbilt. Dr. Blakely.
Congratulations, Dr. Fleming, and to the rest of your group for making this intriguing and I think fairly provocative observation regarding inguinal hernias in premature infants. I think most pediatric surgeons have probably stated at one time or another that inguinal hernias never resolve, whereas umbilical hernias usually do. This information then drives decision-making regarding the repair of these different types of hernia. So your group is to be congratulated on observing this group of infants whose parents had agreed to have the inguinal hernia repaired after 55 weeks post-menstrual age in hopes of reducing the risk associated with that repair. It's nice to see that you have greater than 2 years average follow-up after inguinal hernia resolution. I appreciate the invitation to discuss the paper and thank you for providing the full manuscript. I would urge caution to you and the authors when you report this observation, given the very small number of patients. So I have 3 questions. The first is, do you know for sure that the original diagnosis of an inguinal hernia, especially for the 23 patients that had their hernia resolved, was that always established by an attending pediatric surgeon? Or could that diagnosis be established by another healthcare provider? Secondly, do you or your team at Virginia have any concerns about the possibility of these infants having symptomatic inguinal hernias later in life? For example, if they become pregnant at some point with increased abdominal pressure, what's the likelihood, do you think, that we are avoiding a simple operation now, but maybe getting to a more complicated one later? And lastly, given your findings of a very low incarceration rate and a reasonable possibility that the inguinal hernia will become clinically not apparent, what is the preferred approach for these infants, especially when diagnosed in the NICU currently at UVA? Thank you very much.
Thank you, Dr. Blakely, for your comments and questions. So to answer your first question, we did ensure that the diagnosis was made on physical exam by one of our 4 attending pediatric surgeons. And even if the diagnosis was made initially by a non-pediatric surgeon, we then made sure to confirm that on exam and then documented as such. And then as far as your second question, with the possibility of these infants developing symptomatic inguinal hernias later in life, we do agree that this is a possibility. And it's something that we've thought a lot about, and we feel like the risks associated with an operation later in life or the development of symptomatic inguinal hernias later in life would be no different to adults who are diagnosed with inguinal hernias during adulthood. And then as it relates to female patients who may become pregnant and experience increased abdominal pressure, based on the pregnancy literature, at least, it actually encourages watchful waiting during pregnancy and supports the repair of inguinal hernias or groin hernias in pregnant patients in the postpartum setting. So within that context, we believe that when it comes to pregnant patients especially, they shouldn't suffer any more significant morbidity. And then to answer your third question, about the my apologies, the preferred approach in our NICU setting for our infants. Currently at our institution, we offer repair of the inguinal hernias in our premature infants in a delayed fashion. And so that's after NICU discharge. as long as there are no indications that require an emergent or urgent repair or an early repair before discharge. So currently it's a delayed repair after NICU discharge with close observation and follow-up by one of our attending pediatric surgeons.
Thank you.
Thank you, sir.
Thank you, Doctors Fleming and Blakely, for your presentation and discussion on the clinical regression of inguinal hernias in premature infants.
Our fifth oral presentation will be given by Dr. Andres Gonzalez Salazar from Johns Hopkins Hospital. His presentation is entitled, "A Novel Toll-like Receptor 4 Inhibitor Treats Established NEC in Newborn Mice." Dr. Salazar.
Hello, my name is Andres Gonzalez Salazar, and I want to thank the American Pediatric Surgical Association for giving us the opportunity to present our work. This work was in part supported by a research grant from Genie Life Sciences. Necrotizing enterocolitis is an important gastrointestinal disease of the premature infant. It has a mortality rate that ranges from 20% to up to 50% in patients that require surgery. Those who survive are fraught with both short and long-term complications, such as intestinal strictures, short bowel syndrome, and long-lasting neurodevelopmental impairment. The pathogenesis of necrotizing enterocolitis is multifactorial, but a significant aspect of the disease is how it almost exclusively happens on patients born prematurely. One of the hypotheses that explains the significantly increased risk of premature infants is the overexpression of toll-like receptor 4 in the premature gut. Toll-like receptors are part of the innate immune system and recognize particles derived from bacteria and other pathogens like lipopolysaccharide. Excessive signaling of TLR4 in combination with the dysbiosis present in premature infants might explain the increased risk of NEC. Given this knowledge, inhibition of TLR4 has been targeted as a way to prevent the occurrence of NEC in premature babies. C34 is a TLR4 inhibitor that binds directly to the receptor and has been shown to decrease severity of inflammation in LPS models and also to prevent the development of NEC in vivo animal models. To further test the application of TLR4 inhibitor now as a possible treatment for NEC, we propose the following hypothesis. TLR4 inhibitor C34 reduces the severity of established NEC in mice by reducing TLR4 expression and its subsequent pro-inflammatory cascade. To test this hypothesis, we relied on our experimental NEC mice model. Mice were subjected to gavage feeds with formula containing bacteria obtained from stool samples of patients with NEC. Mice were also subjected to hypoxic injury twice daily. We fed the mice for 5 days, and on day 3, we did intraperitoneal injections of C34 as well as DMSO as controls. These were compared to breastfed and conventional NEC mice. On day 5, ileum was harvested for RNA isolation and PCR, with evaluation of pro-inflammatory and apoptotic markers and histology for evaluation of injury to the ileum. Regarding the PCR results for pro-inflammatory cytokines, we can see that for IL-6, TNF-alpha, and lipocalin-2, there was a significant reduction in the expression levels of the C34 treated group as compared to the NEC group. Apoptotic markers, BCL2 and BAX, were also reduced in the group that was treated with NEC. These results correlated to a decrease in the expression of TLR4 in the ileum. Our histology, we can see that in NEC, there was destruction of the histological architecture of the ileum when compared to our breastfed mice. When giving C34 on day 3 and 4, the injury improved. In conclusion, treatment with TLR4 inhibitor given on day 3 and 4 of our model decreased the severity of NEC by gene expression and also by histologic injury score. This decrease in severity was seen in correlation to a decrease in the expression of TLR4. I want to once again thank APSA for giving us the opportunity to present our work, and I also want to give my biggest thanks to the HACM Lab for all their support throughout these years. I'm happy to answer any questions. Thank you.
Thank you, Dr. Salazar. The invited discussant for this paper is Dr. Brad Warner from Washington University in St. Louis. Dr. Warner.
Hi, Andres. Congratulations for a beautiful presentation. This is sort of typical of what we expect from the HACM lab, is very high quality research, and you're to be congratulated. This is very exciting that this novel TLR4 antagonist can potentially treat established but hopefully non-operative NEC. And I had a few questions. One of the things that you seem to take advantage of is the fact that the preterm gut has, it seems like, greater TLR4 signaling capacity. And why is that?
To target the first question, I think that this is a very important one, and I'm very fascinated by this in terms of, I see it more as the evolutionary aspect of why do preterm babies have high TLR4 signaling. And I think in the development, in the preterm gut, once you're in utero, you require TLR4 as a way to establish, because they mediate the response between the innate immune system and the adaptive immune system, to establish that that harmony between the microbiome and the intestinal gut, the gut response. So I think that it's a more a response of the body, of the fetal gut, to the population of gram-negative bacteria.
You demonstrate success with treating the mice after the onset of NEC, which is great. And would you advocate this anti-TLR4 therapy for infants at risk for NEC? In other words, Bell's stage 1 or Bell's stage 2? When do you think would be the appropriate intervention?
I think the small issue that I have with stage 1, Bell's stage 1 NEC is that I think it's a little bit, although it may be very sensitive, it's not very specific for NEC per se. And I think we would be catching a lot of patients that, although may potentially have NEC, might just have several issues in terms of GI tract motility because of their preterm or other conditions in terms of flomoral allergies, et cetera. I think the best patient selection would be those that have a high inflammatory environment in their gut, maybe 1.5 or 2, because I agree in terms of stage 3 already being something that we need to intervene and do resection.
What would be the downside of this anti-TNF therapy? Anti-TLR4 therapy, is there any expected complications? It would seem that the TLR4 signals a pro-inflammatory response, which can be helpful, actually. And so if you're taking away the ability to mount an inflammatory response, could that be detrimental to the host?
In terms of the potential downsides of TLR4 antagonism, similar to how I related it to transplant therapy, we can see that these patients, babies are going to be in the NICU. They're probably going to be intubated. They can be lined or they have a catheter. So they are a potential risk for infection. So effect of systemic TLR4 antagonism can potentially increase their susceptibility to infections. So I think those are that would be the biggest concern that we would have.
Knowing David's lab pretty well, and they've written a beautiful paper on the synergy between TLR4 receptors and EGF receptor. And they've shown previously that in order for the TLR4 receptor to work completely functional, that it requires the EGF receptor signaling as well. And we know that giving EGF, it's in breast milk, is preventive of NEC. So how do you explain that disparate sort of finding?
This is an excellent question in terms of how EGF interacts with a TLR4. I personally see this, having read a little bit about the topic, in terms of in the gut, in the in utero environment, the EGF source would be the amniotic fluid that is suppressing this inflammatory response that is occurring due to this pro-inflammatory environment that you can have given the high TLR4 signaling. And then when you introduce breast milk, which is another big source of EGF, you also have that protective effect. But I think the critical point is those first 2 weeks of life. Once you are out of the in utero environment and out of that protective effect of the amniotic fluid, and then transitioning into breast milk, these babies will have formula, will be in the NICU, and probably will be lacking this EGF benefit that they can obtain. So I think in that moment, after those first 2 weeks, we would see the effect of the role of EGF in suppressing or incentivizing TLR4 signaling.
It was a beautiful presentation, and thank you for inviting me to discuss this great work.
Thank you, Dr. Gonzalez Salazar and Dr. Warner, for your presentation and discussion on toll-like receptor 4 inhibition in necrotizing enterocolitis. Great job. Thanks, guys.
Our sixth oral presentation will be given by Dr. Emily Onifer from Washington University in St. Louis. Her presentation is entitled Resection-Associated Liver Injury in Murine Model of Short Bowel Syndrome. Dr. Onifer.
Hi, my name is Emily Onifer, and I have nothing to disclose. Intestinal failure-associated liver disease, or IFALD, is one of the major contributors of morbidity and mortality in patients with short bowel syndrome. Initially thought to be secondary to prolonged TPN, the pathogenesis of IFALD is now considered to be multifactorial. As such, we wanted to explore the impact of intestinal resection on the development of IFALD in our TPN-independent mouse model. We performed proximal small bowel resections in comparison to sham control operations in B6 mice, and evaluated for key features of IFALD at long-term time points. Using CK19 staining, resected mice showed cholestasis compared to sham controls at greater than 10 weeks. Additionally, serum markers of cholestatic injury are also significantly elevated in resected mice. At 1.5 years after resection, there is marked periportal fibrosis based on serous red staining, both qualitatively and quantitatively. Also, there is significant inflammation as seen in the rise in AST-ALT markers of hepatitis. At 1.5 years after operation, we were astonished to find significant gross nodularity in all resected mice, which was not present in unoperated or sham controls. Histology revealed severe liver injury, including hepatitis, shown by the red arrows, dropout and collapse, shown by the black arrows, varying degrees of steatosis, shown by the blue arrow, and many pigmented Kupffer cells, necrosis, and regenerative foci. With one resected mouse even showing a frank hepatocellular carcinoma with thickened hepatocyte cords and endothelial wrapping. Given these significant findings, we then focused on determining possible mechanisms for the development of liver injury attributable to small bowel resection. We believe that the mechanism of injury is associated with the gut-liver axis via the transporter HDL. Gut-derived HDL is generated at the ileal segment of the small intestine and is transported into the portal vein by ABCA1. As you can see here, with loss of intestine, there is loss of HDL in the portal blood. This HDL carries endotoxin to the liver via the portal vein. If LPS is bound to HDL, its signal is neutralized and an inflammatory response is not elicited. LPS activity in the portal vein is increased after resection. This is associated with the well-established leaky gut phenomenon due to decreased tight junctions, which you can see here in our model. We believe that this increase in LPS activity is then augmented by the loss of the protective quenching effect of HDL, allowing LPS to stimulate Kupffer cells in the liver and resulting in inflammatory response. We therefore performed resections on Villain-Cree ABCA1 knockout mice, as ABCA1 is the intestinal transporter of HDL into the portal vein. The LPS activity in the portal vein of the knockout mice was significantly higher, as they no longer had HDL to quench that signal compared to wild-type controls. With the loss of portal venous HDL, markers of hepatic inflammation and fibrosis increased. In 75% resected mice, the loss of intestinally derived HDL also showed histological features of worsened fibrosis and inflammation. To determine if HDL sequesters LPS from detection by Kupffer cells in the liver, we co-cultured Kupffer cells with LPS and detected surface binding by flow cytometry. When HDL was added, it robustly prevented LPS interaction with Kupffer cells. LPS activates Kupffer cells via TLR4, causing fibrosis and inflammation. When mice where Kupffer cells selectively lack TLR4 undergo small bowel resection, there is reduced fibrosis and inflammation. In conclusion, we have shown that HDL reduces LPS signaling via Kupffer cells. Small bowel resection results in increased LPS bioactivity in the portal vein, which has been associated with increased intestinal permeability. Additionally, the loss of intestinally derived protective HDL to quench the LPS signal results in increased LPS delivery to the liver, activation of TLR4, and inflammation. This data illustrates that intestinal HDL protects against resection-associated liver damage, and that LXR agonists such as one that is seen here, can increase intestinally derived HDL and decrease the hepatic injury associated with resection in our model. Therefore, we believe that LXR agonists are a potential mechanism for IFELD prevention. Thank you very much, and I would like to particularly thank my collaborator, Yong-Hoo Han.
Thank you, Dr. Onifer. The invited discussant for this paper is Dr. Daniel Levin from the University of Virginia Children's Hospital. Dr. Levin.
Hi, thank you. As Dr. Gander said, I'm Dan Levin from the University of Virginia. I want to congratulate on an excellent talk on a very interesting topic. I have a few questions that I want to follow up on. The first relates to the HDL concentration. You mentioned that the HDL concentration is reduced after 50% bowel resection. And I'm wondering, does the degree of resection increase the magnitude of the change? So in other words, do you see less HDL with 75% resection compared to 50% resection?
Yes, we do actually. So I just wanted to bring up this piece of data for you guys just to see. And I hope that that's working. But if you look at magnitude of resection, you can see the non-op sham 50% and 75%. There's a longitudinal magnitude of decrease in the amount of cholesterol in the portal vein with your loss of bowel. And then secondly, in addition to that, as there's the magnitude decreases, your LPS, which is your activity of LPS in the portal vein, also increases with your loss of bowel.
Excellent. And if I can follow up on the LPS activity a little bit. So you described that increase in LPS activity dependent on the magnitude of the resection. And I'm wondering, what is the time point on that? Is that immediately after resection, or does that persist throughout the entire experimental period?
Yeah, that's a great question, because we obviously wanted to make sure that we weren't measuring LPS activity immediately right after resection, because that would technically just show almost the immediate effects, and you'd expect LPS to be incredibly high anytime anyone has surgery, because you're obviously activating an inflammatory response. Mm-hmm. So the LPS is measured at least 10 weeks after resection. So usually 10 to 15 weeks after operation is what we presented here.
Excellent.
And that's the long-term effects, which are important in terms of looking at intestinal failure associated liver disease as well.
Yeah, absolutely. Thank you. And then finally, you got to touch on a little bit toward the end of the presentation, but I was wondering if you could tell us a little bit more about the LXR agonists and then expand on their possible role in treating or preventing IFELD.
Yeah. So just, I also, in terms of the LXR agonist, we did show that intestinal HDL protects against resection-associated liver damage by protecting it essentially from LPS. And this has been, LXR agonists have actually previously been implicated, you can see here, as actually helping to protect in the development of NASH, so non-alcoholic steatohepatitis, and fatty liver disease and IFELD. And so we wanted to look at whether this would be essentially a potential therapeutic option in our patients with short bowel syndrome. And so to look essentially at the protection for the development of IFELD, we gave this enterally an LXR agonist to these mice and showed that it stimulated both the production of HDL. And you can see here, and I had shown that there was a decrease in fibrosis as well as inflammatory cells here, but there also is a decrease in your ALT, your AST markers of hepatitis, and not shown here, there's also a decrease in your inflammatory markers by PCR in the liver as well. So then, for us, the question becomes, and that these LXR agonists essentially are a way for us to hopefully potentially combat IFELD in our patients, and from a therapeutic perspective, an oral delivery is a great way to do that, to protect the liver. But the problem is, how is this going to interact in terms of the microbiome, as well as protecting intestinal permeability in our patients? And then also, what is the timing and the feasibility for this? When would you actually start giving someone an LXR agonist? Would you start almost initially, right after someone did develop short gut, or would you wait until later when they actually developed intestinal failure-associated liver disease?
Excellent. Thank you very much, and congrats on the great talk.
Thank you. Thank you very much.
Thank you, Drs. Onifer and Levin, for your presentation and discussion on resection-associated liver injury and short bowel syndrome.
Our seventh oral presentation will be given by Ms. Francesca Peters, a medical student at the University of British Columbia. Her presentation is entitled, "The Importance of the Ileocecal Valve and Colon in Achieving Intestinal Independence in Infants with Short Bowel Syndrome." Ms. Peters.
Hello, my name is Francesca and I'm a medical student from the University of British Columbia. I'm going to speak to you today about our project, The Importance of the Ileocecal Valve and Colon in Achieving Intestinal Independence in Infants with Short Bowel Syndrome. I have no disclosures. Infants with intestinal failure require parenteral nutrition, or PN, for growth, but PN has many complications, including central line infections, hepatic cholestasis, mucosal atrophy, and decreased quality of life. Because of these complications, teams and families are motivated to wean infants off of parenteral nutrition as soon as possible, which requires the development of enteral autonomy. Developing enteral autonomy is multifactorial and includes anatomical, clinical, and nutritional factors. 3 anatomical factors often considered are small bowel length, the ileocecal valve, and the length of the colon. The small bowel is well understood and well agreed for its role in developing enteral autonomy. However, the ileocecal valve and colon's role is less clear and results have been inconsistent. Because of this, our question is, how do the ileocecal valve and colon influence the development of enteral autonomy? We performed a retrospective cohort study on infants with short bowel syndrome at the BC Children's Intestinal Rehabilitation Team from 2010 to 2019. Infants were enrolled if they were less than 12 months of age, had prolonged PN use, and we followed them for 3 years from their diagnosis of short bowel syndrome. Our primary outcome was time to enteral autonomy. We found that 79% of our infants weaned within the 3 years. They had a mean small bowel length of 49%, and 61% of them had their ileocecal valve. 70% of them had more than half their colon. The most common etiology was gastroschisis, followed by atresia, and then neck. First, we looked at the duration of parenteral nutrition use. After accounting for percent expected small bowel, we found that those with an ileocecal valve compared to those without had a shorter duration of PN use. We also found that those with more than half their colon compared to less than half also had a shorter duration of PN use. Next, we used a Cox proportional hazards model to assess their ability to predict enteral autonomy or predict weaning. All of our factors were included into a univariate unadjusted hazards ratio model. We found that small bowel length, ileocecal valve present, and colon greater than half were significant predictors, while etiology and gestational age were not. The 2 graphs you can see are Kaplan-Meier curves representing the proportion of patients PN dependent versus time to wean, stratified either by their presence or absence of ileocecal valve or greater than and less than half of the colon. When the significant factors were then put into a multivariate model, we found that small bowel length, ileocecal valve present were both significant factors. However, colon was no longer a significant predictor. Next, we assessed the relationship between the ICV and the colon. Infants were stratified into 4 groups depending on their the presence or absence of ICV and colon greater than or less than half. Comparing to the reference category of ileocecal valve absent and colon less than half, when only a single factor was included, we found that having an ileocecal valve had a stronger effect on the duration of PN use compared to having greater than half the colon. We saw the same thing looking at the hazards ratio model, comparing again to the reference category of ICV absent and colon less than half. When only a single factor was added, having a present ICV had a stronger hazards ratio. In conclusion, we found that in infants with SBS, having the ICV and more colon may decrease the duration of time on PN. The ICV and longer small bowel are positive predictors of developing enteral autonomy, and the ICV and colon may work synergistically, but the ICV may have a stronger effect. Thank you.
Thank you, Ms. Peters. The invited discussant for this paper is Dr. Robert Acton from the University of Minnesota Hospitals and Clinics. Dr. Acton.
Congratulations, Ms. Vels-Peters. You did a wonderful job in your presentation. You've nicely demonstrated what many surgeons have shown in the past, that, and we've known clinically that the ileocecal valve is extraordinarily important to be able to wean a short bowel syndrome child off of TPN. Do have a couple quick questions for you just to clarify a few points. Were you able to see any interaction with determining the length of minimum small bowel present if you still had your ileocecal valve, and any correlations with the ileocecal valve with failure to wean? Did he have any patients that still had their ileocecal valve, but yet were failing to wean off? And and I do like the idea showing that there's significant difference that if a child does have their ileocecal valve and most of their colon, that typically they came off in your program within roughly 200 days. That's wonderful encouragement to some of our families. So again, thank you for a very clean and crisp presentation.
Thank you very much. Yeah, it's a very important kind of question to ask, and especially when talking to families, being able to give them some more tangible information as to what we can expect the outcomes to be. So in regards to the first question about the interaction with the small bowel and the ileocecal valve, initially we were hoping to see if we could factor the ileocecal valve effect out of the small bowel. So we didn't spend as much time analyzing their interaction, but we hope to do that moving forward. However, we did see that on average, the mean small bowel was shorter for our infants with the mean small bowel was shorter for infants without an ileocecal valve. And that was a significant difference that we saw. However, they did still wean, but they took longer to wean. But did still wean within our 3-year period. And so in the future, we'd like to look in more detail at if we provide different weaning cutoffs, say within the first year, do they then require more small bowel to still meet that cutoff if they have no ileocecal valve?
Perfect, thank you. Any other next steps that you have for your program? Is there a child who you would not support up in the University of British Columbia? Is there a child, to clarify, is there a child with such short small bowel length, such short colonic length that you would deem potentially not supportable?
Oh, that's hard for me to speak to the Children's Intestinal Rehab decision-making team. There's a fantastic team of surgeons and dietitians and nutritionists who make most of those decisions. But I know we have many infants with really complicated bowels who end up on long-term home PN, and I believe that they're still supported. And the team makes sure that they have the resources and the support at home to have the nutrition and the PN that they need.
Great, thank you. And again, congratulations on finishing medical school and moving on with residency.
Thank you.
You did a wonderful job.
Thank you.
Thank you, Ms. Peters and Dr. Acton, for your presentation and discussion on the importance of the ileocecal valve in the ability to achieve intestinal independence in short bowel syndrome.
Our 8th oral presentation will be given by Dr. Greg Keefe from Boston Children's Hospital. His presentation is entitled Long-Term Assessment of Bilirubin and Transaminase Trends in Pediatric Intestinal Failure Patients During the Era of Hepatoprotective Parenteral Nutrition. Dr. Keefe.
Thank you for the opportunity to present. We have no disclosures. Intestinal failure, or IF, is the lack of adequate functional intestine required for survival and growth. Parenteral nutrition is life-saving, but is associated with numerous complications, including intestinal failure-associated liver disease, or IF-ALD. The development of IF-ALD is multifactorial, with one element being intravenous lipid administration. The main goal of management is to wean patients off of PN. However, this is not always possible, so hepatoprotective PN strategies have been developed, which are associated with improved transplant-free survival and improved rate of bilirubin normalization. Previous studies have demonstrated persistent ALT elevation despite normal bilirubin levels, which suggests ongoing hepatic inflammation. But these studies were conducted prior to current hepatoprotective PN practices and only included patients who were weaned off of PN. With this in mind, our objective was to determine the long-term relationship between hepatoprotective PN dependence and serum liver tests in IF. We conducted a retrospective cohort study. We included pediatric patients with severe IF, defined as requiring at least 90 days of PN. All patients received one of the lipid emulsion regimens listed, which have been shown to be hepatoprotective in the literature, and followed up in our intestinal rehabilitation clinic between 2012 and 2019. Patients with conditions associated with liver dysfunction other than IF-ALD were excluded. Patients were divided into 3 groups based on level of PN dependence, whether they were enterally autonomous, unmixed EN and PN, defined as 25% or more of their calories coming from EN, or fully PN dependent, defined as less than 25% of the calories obtained from EN. Labs collected during episodes of sepsis were excluded. Log rank testing was performed to generate Kaplan-Meier curves to show the difference in time to normalization of DB and ALT levels. A generalized estimating equation model was used to depict trends in ALT over time. A total of 123 patients were evaluated. Median follow-up was approximately 4 years. The observed significant difference between groups were PN exposure, CLABSI history, and residual bowel length. PN dependence negatively correlated to bowel length. CLABSI rate was associated with duration of PN, as would be expected. These Kaplan-Meier curves demonstrate time to normalization of direct bilirubin on the left and ALT on the right. Percent of patients with elevated lab values are on the y-axis versus time in months on the x-axis. Regarding direct bilirubin, the dotted and dashed lines are the EN and mixed groups, which had normalized their direct bilirubin by 3 years, while 32% of PN patients still had elevated direct bilirubin. Regarding ALT, at 5 years, 73% of the PN group had elevated ALT, compared to 16 and 48% in EN and mixed groups, respectively. This suggests that ALT levels remain elevated longer compared to DB levels, and this elevation was associated with a degree of PN dependence. This is the GEE model of ALT levels versus time in the PN group. ALT level is represented as ratio of measured to normal, and the ALT level decreases over time, does not normalize by 7 years. The limitations of the study include its retrospective nature. It was conducted at a major referral center, thus potentially selecting for a more complex group of patients. Many patients were switched between different lipid emulsions, and limited biopsy data made it difficult to correlate ALT elevation with degree of fibrosis and overall clinical significance. In conclusion, while bilirubin levels tend to normalize, long-term hepatoprotective PN dependence is associated with persistent ALT elevation. Although the clinical significance of ALT level is unclear, it suggests chronic hepatocyte injury not detected by bilirubin, and continued close monitoring is needed. In order to elucidate the clinical significance, we plan to design a study to correlate ALT level with fibrosis scores from non-invasive testing and biopsies. I would like to thank my mentors, Dr. Modi and Dr. Jaksic, along with everyone else that helped with this study. And thank you for listening.
Thank you, Dr. Keefe. The invited discussant for this paper is Dr. Natasha Corbett from the University of Texas Southwestern Medical Center. Dr. Corbett.
Dr. Keefe, I really enjoyed your talk. First question, at your institution, how early is parenteral nutrition that's hepatoprotective initiated in kids that require PN?
During the study period, patients were started on hepatoprotective PN upon PN initiation. This is most frequently lipid restriction. Those expected to require long-term PN were transitioned to smoff-lipid, and those with signs of IFLD and cholestatic liver disease, those are started on Omega-Ven. Currently, we tend to use SMOF as first-line preventive lipid emulsion, and then we start Omega-Ven as rescue upon development of cholestasis.
Thank you. You showed that achieving enteral autonomy in children with intestinal failure really was associated with a shorter time to get to their LFTs normalized, specifically for AST and for direct bilirubin. So 2 questions related to that finding. In children who reach enteral autonomy faster, meaning a shorter time of being on hepatoprotective PN, do their LFTs normalize faster?
So in this cohort, yes. For example, the median time to normalization for ALT for patients with PN exposure less than 500 days is about 65 days, while those with greater than 500 days of parenteral nutrition, their median time to normalization of ALT was about 1.5 years after weaning from PN. This is the general trend, but other factors influencing this are the type of lipid emulsion, but also the percent of caloric intake from parenteral and enteral nutrition.
Certainly. Second question related to that finding is that I was curious to know, what exactly is the average length of time to ALT normalization after reaching enteral autonomy? So basically, the kids that had intestinal failure after they reached enteral autonomy, that your EN group in the study, how long did it take for their ALT to normalize on average? And then also, when do you expect to stop checking labs in those kids that have reached enteral autonomy?
Of the patients in the EN group who normalized their ALT levels during the study period, the median time to normalization was about 18 months. I think it's unclear if or when we can stop checking labs in this patient population, and it's probably best to be a patient-specific decision. For patients with minimal exposure to PN and no history of significant liver disease, their surveillance of liver function can likely be less frequent, but should not altogether be abandoned. Because normalization of LFTs doesn't necessarily mean that the liver isn't undergoing fibrotic changes. There's been previous studies that have shown that patients with hepatoprotective PN who undergo liver transplant can have normalization of their LFTs, but have a cirrhotic explanted liver. And that's why it's important to not only monitor liver function tests, but also monitor overall liver health with fiber scans, ultrasounds, as well as biopsies.
Okay. On your GEE model, you showed that children with intestinal failure and hepatoprotective PN dependence, they'll continue to have elevated but declining ALT, even up to 7 years after the parenteral nutrition was initiated. That seems a little bit unexpected to me. I'm curious, would you expect to see cumulative worsening liver function with longer durations of PN? That's what I would expect. And also, do you know if the ALT would be persistently elevated if you weren't on hepatoprotective PN? If you looked at the same kids that weren't on, Omegavin, if they were on non-hepatoprotective PN, would you still expect their ALT to be persistently elevated up to 7 years out?
So the majority of the patients in the PN group were treated with Omegavin, which has been shown to improve levels of hepatic biomarkers. Prior to the development of hepatoprotective PN, about 65% of patients would develop liver dysfunction. And of those, about 15 to 50% would then progress to end-stage liver disease. So in patients not treated with hepatoprotective PN and who develop IFILD, regarding the ALT levels, we would not expect levels to normalize without altering the PN strategy. However, you may not necessarily see levels increase due to chronic inflammation and development of fibrosis. And you may in fact see a decrease in the ALT over time, like those that received Omegavin in this study, as there's a decrease in normal hepatocyte function and the organ becoming somewhat burnt out. But you would expect to see acute increases in levels during episodes of sepsis, as well as perioperative states.
Okay, last question. Similarly, you in your GE model, you showed that the ALT was persistently elevated, but decreasing. But you also showed that the ALT didn't really exceed more than 2 times the upper limit of normal. And so I'm curious to know if you think that this mild degree of ALT elevation over long periods is really clinically significant, or if the ALT has to be elevated at a certain level in order for it to be impactful in terms of liver fibrosis and progression to cirrhosis.
So this is a great question, and we believe that the mild but sustained increased ALT level is likely due to chronic hepatic inflammation. And as survival of patients with intestinal failure continues to improve, we don't know if this is going to lead to the development of cirrhosis or hepatocellular carcinoma later in life, which is why there's need for further investigation. But this also underlines the need to closely monitor liver function in these patients with non-invasive testing, additionally to the routine laboratory studies.
Well, thank you very much.
Thank you.
Thank you, Drs. Keefe and Corbett, for your presentation and discussion on bilirubin and transaminase trends in intestinal failure patients. Thank you. This concludes the 2021 virtual APSA scientific session on neonatal surgery. The APSA committee and this session's moderators, participants, and discussants would like to thank you for your attention.